All right. Of course, we have more cases. We have more questions. The night is young, and I am not. So let's put 2 minutes on the clock, and your time starts now. All right. So this is one of those cases where they already know that you almost certainly know the answer to what is the diagnosis. And so they'll often come out and specify this is, toe fascious gout. What they want to know here is why. And so what they're really asking is what are the risk factors for toe fascious gout, or gout in general, really? And of course, he has increased age, genetic predisposition, pure-in-rich diet, alcohol use, diuretic or hydrochlorothiazide use, and here it doesn't specify that he has diabetes at all, and so I don't think you'd actually get any marks for that there. Where this gets a bit vague is that there's no obvious genetic history here. There is some evidence to say some Asian populations can be at increased risk compared to other populations, but it's one of those things you do have to make some presumptions, and what's frustrating is they don't always let you know which assumptions are safe to make and which times they're saying, oh, well, we didn't put that in the STEM, you've actually given us made up information. Sometimes you've just got to try and go with your gut there and work out what you think is going to be that right answer. And this is, of course, where practice, going through these questions again and again is going to be the best way to work out what is the right or most appropriate answer in this case. And so here, I think you'd be pretty safe by putting down most of those things there, but I'd say the diabetes risk is probably a bit too risky in this circumstance. All right, now let's get to question number 2. We'll put 2 minutes on the clock and your time starts now. All right, so 2 minutes is up. Let's get to the answers here. This is, I think, a pretty standard question in terms of what's going to be the best bang for buck in terms of actually confirming the diagnosis here. Clinically, we've already pretty much made up our mind, but it is good to rule out any other pseudo-gout or other monoarthropathies. And so here, things like a joint aspiration, you could actually send off to check if we have negative or positive bifringent crystals, would be appropriate. Serum uric acid levels would be absolutely fantastic in terms of actually checking what is that, and you'd be able to use that as well to try and work on suppressing that. And of course, X-ray of the left foot, to actually check the joint space and see if there's any other kind of erosions or destruction of the bone that may actually point you in a different direction or different, pardon me, diagnosis. So hopefully you've got some things there. Now the joint aspiration here I think would be worth more marks because this is really going to be that gold standard test for confirming the diagnosis, actually getting those crystals under a microscope to confirm exactly what you're dealing with. All right, let's move on then. So we'll get to question 3, case number 2. 2 minutes on the clock, and your time starts now. Oh, this is one of those questions they love because everyone falls for their dastardly little trap of saying, oh, yep, we'll give them an NSAID, we'll give them ibuprofen, good pain relief, and yes, usually recommended for patients with gout. But this patient's on candesartan and hydrochlorothiazide. So using an NSAID in this case would be the triple whammy and would result in a 0 for the question. Now, of course, one thing here that you would be specifying is cease hydrochlorothiazide. And in that instance, it may actually be that they could consider giving you a mark, but I think that would be on a case-by-case basis. Of course, things you could try would be a local corticosteroid injection into that joint space, oral prednisolone. Again, dosing's not specified, but one of those handy ones to know. The recommendations now are 15 to 30 milligrams oral daily. Of course, ceasing that hydrochlorothiazide, and allopurinol would not be indicated in the acute setting. You always wait for that acute exacerbation to settle down before commencing your lowering agents. So hopefully you didn't use an NSAID here.